Good morning. I'm really grateful that we got the opportunity to participate today in this conference. My name is Aus. I'm from New Vision University. I'm a student. My topic today is actually about immunological aspects of tobacco smoking. Before I start my presentation, I would like to say why I chose this topic actually. All of us know that tobacco smoke is a big etiology standing behind a lot of morbidities and mortalities. But the mechanisms behind this etiology really interesting. Especially that this link between tobacco and other diseases such as adverse health effects established just before 45 years when the General Surgeon of Health Services in the United States, they announced that it really has an impact on our health. So in my presentation, I will go through the general aspects from the immunological point of view of tobacco smoking, and also I will highlight just two diseases here, the respiratory diseases and the cardiovascular diseases. I will end my presentation with the effect of smoking, cessation, and so on. So a few key facts. According to the WHO, tobacco is the only legal drug which kills like many of its users when it's actually used exactly as intended by the manufacturers. It kills like half of its users. 7 million people die from tobacco smoke each year. 6 million are from direct smoking. The rest are from second-hand smoking. These actually very big numbers, and that will drive us to know more about this etiology, especially from the immunological part. As I can explain, this effect will mainly be focused on the pro-inflammatory and immunosuppressive effect of the tobacco smoke. It depends actually on the dose and the way of exposure, such as chronicity and so on, and also other factors which exist at the same time when you smoke, such as pathogens and so on. So the adverse health effects actually, we can summarize it by the increased risk for a lot of morbidities, such as the coronary heart disease and stroke, which is increased by 2 to 4 times in smokers comparing with non-smokers. Lung cancer by 25 times in women and men in average. Also 12 to 13 times they're likely to suffer from COPD in smokers. So the cigarette compounds actually, really there's so many toxins there. We focus mainly on the immunomodulatory toxins such as the nicotine, the carbon monoxide, and acrolein and reactive oxidant substances. There's also a lot of toxins such as which cause addiction and the carcinogenic, but that's not our topic today. So the immunological aspects, really big topic. So here we'll focus at the main players in the immune system. We all know that we have the innate and adaptive immunity. The cells which really affected from the tobacco use are mainly the T and B lymphocytes, the natural killer cells, neutrophils, and macrophage, and the dendritic cells. In this chart, actually, you will see here that really different aspects we have here, either by increasing the response of the immune system or by decreasing the response of the immune system. If we pay attention to the macrophage, for example, in the innate immunity, their cell percentage, their number will increase, their tool-like receptors will also be increased, their secretion of the cytokines and so on will decrease. For example, the natural killer cells, their perforin active action will decrease in smokers. Dendritic cells, which is actually a main player here in the immune system, their toll-like receptor will increase. That will cause an increased response to the pathogens. In adaptive immunity, the B cells, their IgE secretion will increase. The IgA and IgG and IgM will decrease. The T regulator cell, which is another important player here, which is can be connected to the autoimmunity because of the decreased secretion of the interleukin 10, which all we know that is suppressing the action of the immune system. and so on with the other T cells, T helper cells. I will explain here also about the cell signaling, which a lot of cell signaling pathways affected actually, but here I just brought 2 examples. The lymphocytes, for example, their activity and the activation of the nuclear factor KEDA will increase, that will cause an increased expression of the cyclooxygenase 2 and induce nitric oxide synthase. And I will explain soon what it can cause in our body. The MAPK pathway and the activator between 1 pathway also increase the gene expression for interleukin 8, which we all know that's an important chemotactic in the immune system for neutrophils and so on, especially in the pulmonary leukocytes. The first disease in our presentation here is the respiratory disease. A lot of morbidities here can be either as chronic inflammation or either by lung cancer and so on. As I say, it can be either by immunosuppression effect or a pro-inflammatory effect. The main factor here actually is the reactive oxygen substances, which is damage to epithelial cells, and also the recruitment of the immune cells at the site of the epithelial lining and so on. Here we can have the example of how it affects the mucous lining, such as impairing the ciliary motility, also increasing in number of goblet cells, which increasing further mucus secretion, which can cause a good flora for the pathogens to grow there. Also, the destruction of epithelial signaling and production of the surfactant will be impaired in smokers. Here, for example, gingivitis, which is caused by smoking, and as a big etiology behind it, especially by the extracts from smoking, can cause a decreased function or suppressing the human beta deficiency 2, which is really needed in these cells for defending the pathogens. Here in this chart, if you pay attention, please, you will have summarizing the whole factors which is causing the chronic airway inflammation. As we said, by the cytokines increasing secretions in the epithelial lining, and also by enhancing the reactivity to inhaled antigens and so on. All of this will cause chronic airway inflammation. The consequences actually by the destruction of the matrix by the matrix, as we know, matrix degeneration by the matrix proteinases and so on, which is secreted from the immune cells, will cause further and further inflammation, and that will maintain the inflammatory status in smokers. Here I will also talk about the asthma and COPD as the immunological aspect in smokers, because when I prepared the presentation, I thought actually that it really affects smokers in so different mechanisms, especially by, as we know, there are already inflammation status in these patients, in the asthmatic and COPD patients, but smokers have more neutrophils and interleukin 8 in their bronchial secretion. The one big mechanism which is also contributing to the decreased lung function in the asthmatic and COPD patients, actually the response to the corticosteroids. Also, the airway inflammation they have more TCD positive, A positive cells and macrophage, and also reduced FEV1. Here I will explain more about the mechanism which is standing behind the corticosteroid irresponsive, because really affecting the asthmatic patients, and it can be also enhanced when they quit smoking. So if you notice here that the cigarette smoke producing the superoxide in our body, and also the nitric oxide which coming from the inflammatory cells by the induced nitric oxide synthase. Both of them, the superoxide and the nitric oxide, mix together, generating the peroxynitrate, which gonna affect the histone deacetylase 2, which reducing its activity. When it's reduced, actually, that will cause the decreased response to steroids and also the increased inflammatory gene expression. Now, the lung cancer, really big. Yeah, okay. So it's really a big topic. Here I'm just going to highlight the KRAS mutation. Okay, we know that also P53 will be affected from smoking and everything. The inflammation will cause also cancer, but the KRAS mutation will cause an increased expression for COX-2, the cyclooxygenase 2, and also will increase the prostaglandin A2. The prostaglandin A2 actually will affect the function of the ACE adherent, which is really needed to maintain the cell adhesion with the epithelial lining. That will cause the epithelial mesenchymal transmission, which is actually a very big factor in the lung cancer progression and initiation. Here also you can see like how healthy and smoking lungs different from each other. Another the final disease we're going to talk about is actually cardiovascular diseases. Briefly, that the factors which really standing behind this etiology are the vasomotor dysfunction, the inflammation, and the lipid peroxidation. Mainly vasomotor dysfunction like increase the nitric oxide synthase from the endothelial cells. Okay, and leukocytes and VCAM and ICAM and everything will be increased in endothelial cells. Yeah, okay, I know, I'm running out of time. Okay. Okay, so the oxidative stress actually in smokers will be increased. That will cause thrombotic, like atherosclerotic thrombotic progression and initiation by the oxidative stress. So it's time to quit. If anyone is smoking here, please. The effect of cessation, showing it. The effect of cessation actually can be immediately. After 20 minutes, you will have the heart rate and blood pressure coming back to normal, and also after 12 hours, you will have monoxide levels will back to normal, and so on. After 10 years, you will have really decreased risk for a lot of morbidity. So finally, also, as I said, quitting smoking actually will reduce the decrease the neutrophil count in asthmatic patients, and also will improve the lung function, but it won't affect the corticosteroid responsiveness, unfortunately. Here, as a take-home message, if you notice that the main aim from this presentation actually that we all need to know that these mechanisms are actually very important to be investigated further and further by more objective scientific data and more active research. So that's what is going to provide us more like an open door for treatment and so on for these diseases induced by smoking. Thank you everyone. Thank you for attention. Sorry for.